Uh-oh. I'm just destroying your equipment right now.
I would like to thank Dr. Robbins for coming today. Dr. Robbins is going to be discussing psychotic disorders in children and adolescents. Dr. Robbins attended State University of New York at Downstate Medical School. He completed his residency in psychiatry and his fellowship in child and adolescent psychiatry at the University of Colorado Medical Center in Denver. And he is currently the Division Director of Child and Adolescent Psychiatry at Maine Medical Center and the Medical Director for Child Psychiatry at Spring Harbor. So thank you very much, Dr. Robbins, for coming today. And look forward to it.
Okay, thank you. I'll actually give a brief update on that introduction. The Medical Director at Spring Harbor now is Dr. Sally Cooper, who fills these large shoes left behind by Dr. Kinley, who was in that position. So I'm not directly there so much at this point. So thanks for inviting me to talk with you about this. This is, I think it's important stuff and a huge area, I think, of leverage to make some major differences in some people's lives who are, if left to their own devices, headed for a really severe, essentially catastrophic course of illness over the course of their lives. And by catching this as early as possible, we can make a big difference. So that's really the bottom line about all this. And part of that involves picking up on it and looking into things before we usually would get concerned. Because there's a quality of kind of optimistic, benign neglect with kids. Let's hope it's just a phase and Johnny's going to grow out of this, or it's just a response to a bad teacher or a problem with a girlfriend, boyfriend, or a divorce of the parents, you know, all of which are very reasonable ideas, but sometimes it's more than that. And by kind of waiting and hoping, watchful waiting, sometimes things deteriorate, and intervening earlier makes a big difference. So it's well known now that most of the major mental illnesses that end up in our psychiatric hospitals, emergency rooms, and so on, and are major problems for the healthcare system, really start very early. And this pointer is, for some reason, doesn't seem to work on the screen, so I'll have to just imagine. So most of major psychiatric disorders, major Axis I disorders under the DSM-IV, are starting in adolescence and early adulthood, something like 50% before age 14. That's very young. And yet, when you look back at when you talk with a person with bipolar disorder, recurrent severe major depression, schizophrenia, it's not uncommon that you hear a story of beginning to have difficulty early on, but typically not diagnosis and not treatment till much later. With major depression, very frequently the onset is in adolescence, and when the onset is earlier, it's associated with greater impairment over their lifetime, more risk of suicide. Bipolar disorder, half to two-thirds have onset before age 18. It usually has first started with an episode of depression in adolescence. So that means if I'm seeing a 16-year-old who has a major depressive disorder, that person might be someone who's going to develop bipolar disorder, even well, at that point there may not be any clear indicators that that's the case. And there are two poorer outcome in the earlier onset group. So, and then in schizophrenia, the first episode of psychosis, first of all, schizophrenia, you know, is now being thought of, and we'll talk more about this, in a very different way. We think of schizophrenia as being equivalent with psychotic episodes, but essentially it's a neurodevelopmental illness that is just started way before the person first presents with psychosis. The psychosis is a state of decompensation which happens later on, and generally there have been some neurocognitive deficits which are unfortunately fairly non-specific, so it's not like we can do some wonderful psych testing on all the 8-year-olds and know who's going to have schizophrenia. Those deficits as they look, executive function deficits and other problems early on, have multiple outcomes, of which this is one. So we can't really target these kids extremely accurately at the very early point. The first psychotic experience, though, is typically in adolescence or early adulthood, in 16 and 25 in 75% of cases. And well, let me back up just briefly. Where this, we have a project now that's funded by the Substance Abuse and Mental Health Services Administration, SAMHSA. It's linked with an initiative from National Institute of Mental Health on first episode psychotic episodes, because again, benign neglect or whatever, people are often drifting along with really strikingly severe symptoms, but they haven't had a crisis that gets them into an emergency room. They haven't been bizarre enough, or they haven't tried to hurt themselves or someone else. They end up not in, and when it's below those thresholds, those sort of rather coarse indicators, we tend to hope for the best and not to assume the worst in terms of the prognosis. And so the duration of untreated psychosis in people is commonly a couple of years. And when you think about it, well, how in the world can people be walking around hearing voices or having paranoid delusions and nobody notices it? But they're often quietly functioning externally relatively well, not all that well, but not that different from other people who might be having a little depression or some family difficulties. So it's not obvious. But when studies have been done comparing people who got into treatment early in that whole process as opposed to later, in absolutely every study, the early ones win in terms of their trajectory of function, their functioning 5, 10, 20 years out. So for all these illnesses, there's essentially a pattern of progression from more nonspecific, nonspecific symptoms and lower levels of impairment to more severe. So from more nonspecific risk states to states of being very high risk to being overtly ill. And so in major depression, an example of the nonspecific increased risk state is your parent has a major depressive disorder or bipolar disorder. You are hugely at risk. And yet you're probably functioning okay. If you add that along with also having, again, I keep trying to make the pointer work, it's not going to work. No, I'm going to give up. If you also have a minor level of depression, what would be called in the previous DSM-IV dysthymia, plus a family history like that, you're at very high risk. Still, it's not a slam dunk. You don't have the illness. Similarly, with bipolar, offspring at risk or hugely at risk. A person with a bipolar parent, bipolar 1 parent, has about a 45% probability of some mood disorder, and about half of those, it's a risk for bipolar disorder, and about half it's a risk for major depression. So they're a huge risk relative to the general population, where the prevalence of bipolar disorder is like 1.5%. And there too, very high risk would be if you have a family history of bipolar and you're experiencing major depressive disorder, particularly if it's with psychotic symptoms, abrupt onset, or if you've become agitated when you're on antidepressants. Now with schizophrenia, offspring are at risk, and there's been a number of studies looking at a clinical high-risk state, which involves positive symptoms of psychosis, but below the threshold where they're truly psychotic. And we'll talk more about that. But where you're starting to have some odd ideas, your general functioning is going down, but you still have reality testing. You say, well, I keep thinking, well, maybe that TV show is really trying to give me a message about my life. But I know that's nuts. That's not happening. But I keep having that thought. And then, of course, the overt illness. So in terms of just terminology, psychosis is defined really in terms of positive and negative symptoms. Positive means things that are happening that generally don't happen with most people, like delusions that of a paranoid nature or otherwise, also grandiose delusions or morbid depressive delusions, thinking that things are the way, some way other than they truly are. But the paranoid, in terms of schizophrenia, suspiciousness is a common one. hallucinations, disorganized thinking, loss of the fluency and organization of thought. And for instance, a father of a girl that we had at Spring Harbor Hospital, one of the earliest signs that his wife described about his starting to have trouble was that good friends, people who knew them well, were saying, we're just having trouble following what he's saying. He gets started talking about something, and then it's on to something else, and we don't quite get what his point was. And it didn't used to be that way. So, and then subsequently he had more clearly an onset of schizophrenia. In his case, it was in his 30s. It was not early. There's also, this is more tricky to or if not impossible at this moment, to disentangle from lots of other things. These are all very nonspecific. But the negative symptoms, and these are things you might see with somebody with schizophrenia when the psychosis is resolved and they're no longer hearing voices and so on. The meds have done their thing. But these are things that tend to be more lingering and more persistent and also can be preceding the rest. And that's what decreases of motivation, low energy, anhedonia, inability to experience pleasure, socialization, decreased expressiveness. That's not really a clear term there, but just a kind of social withdrawal. And so, again, when just imagine somebody who shows all those things, they might very correctly be thought to be depressed. This might be a depressed adolescent you're talking about. So these are non-specific, but these are equally important. And this category of symptoms actually correlate very well with problems down the road. Because these are things that really impair your life and don't necessarily improve that well with medication. So these are a real challenge. Psychosis is a broad term. It's essentially a syndrome, a kind of final common pathway of the way the nervous system can respond. And it can happen in many disorders. We tend to think of it as being equivalent with schizophrenia, but it also happens in all these other things. People with bipolar disorder, depression, OCD can present with psychosis. Certainly lots of drugs can cause it. A number of medical illnesses, it can be associated with delirium, and essentially that can, at one moment in time, can look very much like psychosis for other reasons, but usually it's more cognitive impairment. It can occur in PTSD. So it doesn't mean necessarily schizophrenia. It's a broader term than that. Nevertheless, once it develops, it's associated with poorer prognosis and a number of secondary problematic developments. These are some of the early signs that one can see. Some people become overly sensitive to sounds, bright lights. That may lead to more social isolation. They just don't want to be around too much. They describe things as being too confusing, too overstimulating. Stresses that previously they might have managed well now kind of get on their nerves and kind of overload their circuits more readily. Things that they get confused, they try to keep things simple. They may respond more poorly, more dramatically, and in a negative way to drugs and alcohol. Somebody who previously could socially use alcohol or marijuana with their friends now gets really, really anxious or extremely paranoid, and that didn't used to happen. So there's a shift in the sensitivity. So those are some early signs, but again, they're nonspecific. We know if you just pick up people who show all those things, you're going to have lots of false positive identifications, and yet somebody would show this kind of picture, it needs to be checked out. Here's some other kind of examples. A vague feeling that something's not right, unusual thoughts and confusion, feeling fearful and anxious, and when hearing sounds and voices that are not there, but often still with preservation of reality testing. Like I keep hearing somebody calling my name. I keep hearing this whooshing sound, but there's nothing there. But it's troubling. It distracts me. Maybe it's real enough that I look and check, but nothing's there, and then I kind of try to move on, and yet it happens again, and it keeps on going. And then withdrawal, losing interest in things, and trouble communicating. So first episodes of psychosis, consistent with what we were saying before, typically start in adolescence and early adulthood, often go without treatment, longer periods of lack of treatment are markedly associated with poorer prognosis, and early intervention is effective. I'll say more about that. So why does earlier treatment help? A number of different ways of thinking about this. One is the longer people are in this syndrome, supports start falling away. You know, they're too strange or difficult, or in some cases disturbing, to be at high school, and they're told, you know, maybe you shouldn't come back, or it becomes not reinforcing to go, and so they start avoiding it. Families can move from being supportive to being very frustrated and becoming very critical and angry. Talk more about that. So lots of things start to kind of unravel in ways that make things worse. They obviously, they're losing out on school and job experience and learning the skills that we all need to have learned when we were, you know, 18 and 20 and so on. That is still, you know, we're all still a work in progress at this point in our lives, and this is then kind of coming to a halt. Positive sense of self, and that's a more ambiguous idea, but they start losing a sense of agency to control their lives, a sense of that, you know, they really don't have much control, and they start having reason to think things are not going to turn out well for them, and they stop trying and become more passive. That can be very, very problematic. That should be the other way around. It's a decrease in adverse experience. That's an increase. When you're in this state, bad things happen to you. You don't take care of yourself. Assault, sexual assault, loss of relationships. Got to go back and change that slide. Are all clearly more common. And even some things that we wish were helpful are sometimes traumatic. The experience of being hospitalized in a psychiatric hospital is often traumatic. It means you were taken against your will to an emergency room. You might have been held down by big guys who give you IM injections in your butt, and you know this is a traumatic experience. It may have been necessary at the time, but nevertheless, it is difficult. But again, all sorts of things. There's a kind of, when people are severely mentally ill for various reasons, there's a downward social mobility. I mean, you know. You can't pay your rent, and now you're homeless, and you know, so on. So bad things tend to accrue. A whole different area that's just really starting to be studied, we'll talk more about this, is that there actually is a neurotoxic effect of the decompensated state that we call psychosis. That being ill actually harms your brain, and the illness at the biological level becomes more severe. And we'll talk more about this, but there's a lot of work on epigenetic effects of adverse experience, the availability of sections of your chromosomes for transcription changes in response to experience. There's wonderful studies in rats and observations in people about this that then have lifelong effects on different aspects of your psychosocial functioning. For instance, baby rats treated or raised by parents with mama rats with less caretaking capacity grow up to have more difficulty with emotional regulation. You can do this with all sorts of little studies with rats, and that's in response to the experience, not to the genetics. So it's a fascinating piece of work, largely done by the lab of a guy named Michael Meany in Canada. I'm not going to talk a lot about that, but I'll come back to this a little bit. Elevated cortisol, which is seen in various states of stress, is clearly known to have a neurotoxic effect. I'll say a little bit more about that. And also CNS inflammation, elevated pro-inflammatory cytokines and some other compounds have negative effects on our brains, which are lasting. And I'll say more about that too. And some things protect from this. Omega-3 fatty acids seem to have a protective effect. And curiously, some of the meds that we use for treating psychiatric disorders, lithium and the SSRIs, have a protective effect. When you grow neurons in vitro in a lab, if you expose them to a little bit of cortisol, or in the case of bats, corticosterone, you will see less dendrite proliferation. They don't grow as robustly. If they've been pre-treated with lithium, they're more resistant to the toxic effect of the cortisol. So it's a fascinating model of what might go on with people. That's a very early stage yet, not really all proven. But, RAISE is an NIMH initiative about getting in there early with an initial episode of psychosis, particularly this is about schizophrenia. So the RAISE acronym means Recovery After an Initial Schizophrenia Episode. It's been going on for a number of years now. There's some reports that have come out, and one of them, for this later, it was talked about in the New York Times just earlier this week. Dr. John Kane, K-A-N-E, and others were reporting on essentially treatment with this package of services, and with really markedly better effects than just treatment as usual. So this involves, for one thing, you have all the treatment delivered by a team that's getting together and talking with each other and comparing notes on a regular basis, as opposed to business as usual, which means, somebody comes to see me in the psych clinic and they've got a therapist across town in another agency, and they see one of you for primary care, and they may or may not have a job or education support counselor person. Often they don't. There's no care coordinator. So having all this together as a single team pays off. And actually, it's an interesting thing. It's a little, if from a healthcare economics point of view or administration point of view, how do I justify having all these expensive people take an hour twice a week to sit in a room and chat? I mean, that's actually a very expensive intervention, a thing to do. How does Maine Medical Center or Intermed or anybody else, take us all offline and have us just sit around and talk about our patients? And yet, in fact, I think there is very definite economic value in it. The overall efficiency of what's getting done and the effect and the outcomes are very different. So that's an interesting kind of medical economics. Care coordination, very simple, and it's been done all over healthcare increasingly. Mental health is slow to come online with doing this, but it makes a huge difference. And it's a big study in bipolar adults in the VA system where they put in, they didn't train anybody in new evidence-based practices, just keep doing whatever the heck you do. But what was different was in 5 centers, they had a care coordinator just bird-dogging what's going on with Mr. Jones. Does he make it to his appointments? What are the barriers? Is he understanding what's going on, what he needs to do? And in others, they didn't. Drastically better function. So again, you're not teaching anybody any new tricks. You're not being told which meds to use. Just simply helping people with the follow-through. And we know that's true for diabetes, hypertension, you name it. Supported employment, education, very important, because these folks are often puzzling to schools and to employers, and they're going to need a little help in how they present themselves. Employers may need some help to have schools have patience and flexibility, and yet that hugely pays off. Psychotherapy, we tend to think of people with psychosis as being beyond the reach of individual talk therapy, and that's really not the case. There's been careful thinking about how you address psychosis, and some of this sounds very low-tech, like talking back to the voices, like just, I have a boy I saw yesterday, very high-functioning kid. He's been ill only for a few months, but he's got it bad. He has just persistent paranoid thoughts, also some depressive thoughts. Because the fact that the content of his delusions is somewhat depressive, like I'm a bad person, I must have done something bad earlier, I deserve to be punished, despite tons of reinforcement that that's not the case. And from parents, school, teachers, friends, everyone, these thoughts keep coming back. And it's dangerous, because somebody who gets locked into that line of thinking can be at risk for thinking the world would be better off without me, and maybe I'm doing everybody a favor by ending my life. And so it's a very risky state. And so he's being worked with a therapist who's been trained in this to almost have a kind of a script almost in his head. When I hear that, I tell myself it's not true, or I tell myself, to check with my mom about whether I really did run over somebody with my car yesterday and leave them to die on the side of the road. And she'll say, well, of course not, and And again, this has to happen repeatedly. It's not simple, but it has a positive effect. Family education support is huge, and because families, the best of families will start doing some things that can make things worse. And that's been the particular focus of the previous program that many of you have heard about in Portland called the PEER program, run by Dr. Bill McFarland. His main interest is in family education and support, and that's a very, very important part of the picture. And evidence-based meds, of course, is really important, and coordination with primary care. Now, just to say a word about that, we know that people with severe mental illness, such as people with schizophrenia, have something like about a 25-year earlier mortality. I mean, it's a drastic increase in earlier death for lots of different reasons. Not taking care of yourself, metabolic syndrome associated with the meds that people like me prescribe for them, lots of reasons for bad outcomes. And so they have and they typically don't have good primary care because they're not part of not taking care of themselves. They're not showing up for appointments, and they're difficult customers in the waiting room and so on. So this is tricky. Now, when we're catching them early like this, we don't see any of that. So it's easy to say, well, we'll deal with that when the person's 30. But okay, I think starting to pay attention to this and sort of educate the young person and their family, this is really important, is really critical. When I think of the people in our project now, essentially none of them are having major medical problems, and yet we know that they're all sort of headed for a hugely increased likelihood of poor outcomes medically. So that's important. Now, this is the New York Times article I referred to, and you can find it online, and both the New York Times article and it's out in the American Journal of Psychiatry last issue. And the idea that whole laundry list of things that work, you know, medication is just part of the picture. When we tend to think, psychiatrists tend to think too much about focusing on pharmacotherapy, which is critically important in the acute phase, but it's not the whole picture. And if you just focus on that, you're going to really miss the boat. And yet, anyway, and this talks about it. And I think that the headline in the New York Times is something like "Talk therapy found to ease schizophrenia." You know, so that's important. So I need to kind of watch the clock. I'm not talk too much about everything, but this is about, there's more, and we could talk about this more, or even look into some of what I've just been saying. The psychosis high-risk state, sub-threshold symptoms of psychosis, positive family histories. Now, when you see this constellation of symptoms, those folks untreated have a rate of progression to overt psychosis within a year of, it's 8 to 40%. In the ballpark of around 20–25% of those will develop psychosis within a year. And in some early studies, it was as high as 40. That's huge. You know, if you can say, okay, 4 out of 5 of these people are not going to develop psychosis in a year, but 1 out of 5 is, compared to, like, you know, less than 1% for a given point in time for the general population. That's a hugely valuable early identification factor, even though, you know, within a year, you know, a good number of them may not develop the illness. But nevertheless, these are a very high-risk category of people, and that needs to be attended to. And the lower value is what you see with treatment, and we'll talk more about that. Looking at a number of different randomized controlled studies, this is a meta-analysis done a couple of years ago, huge difference. That in that group, the untreated controls left to their own devices, 23% of them have a psychotic episode within a year, and it's under 8% in the groups who had treatment. What's interesting, so a hugely positive effect. And in most cases, this treatment is relatively low-tech. The antipsychotic medication component is not the most potent thing to do. So it's not like one is going to be giving, you know, risperidone to people who don't need it. In most cases, most of what you do is not is psychosocial treatments, cognitive behavioral therapy, family psychoeducation, also omega-3 fatty acids. Actually, the strongest positive result has been in the study with omega-3 fatty acids, which is fascinating. It's being replicated now, and the early word on that on a big replication study is that the effect is as strong or stronger than in the initial study. So the point is, there's a huge difference that can be made. And when followed out, like that 23% of controls within a year, that's about 35% become seriously ill within 2 years, and that's likely to increase further out. Just very briefly, the cost effectiveness, I think, is really interesting. In the first year, this is from a study in England. They're just starting to have some good cost effectiveness studies. In the first year, when you're actually, this is the first 6 months, when you're treating people more actively, you actually spend a little bit more on the people that you treat than on the controls, which kind of makes sense. You're doing something. But when you follow them up over 1 to 3 years, hugely different, hugely lower costs in the people with SP, that means specific preventive intervention. They're costing over 12 to 36 months, $5,500. The people who were left to treatment as usual are costing $11,500, and that's mostly from psychiatric hospitalization. So, so economically, this makes a lot of sense. And that article that you've got by Patrick McGorry, he's in Melbourne, one of the groups who's really done the really excellent work on this. It's a very strong kind of statement for how we really need to transform where we put our dollars. You know, it's not, we will never want to not treat people with more advanced illness. So we want to do what we can to help them function. But right now, that gobbles up, you know, the lion's share of our mental health dollar. And we spent almost nothing on this. And we really need to switch that around. So this is the program here in Maine with this SAMHSA grant. We're calling it, again, the PEER program, which stands for Portland Identification Early Referral, because there's a lot of recognition of that name, and the same concept still makes sense. It's different from the earlier one in that the earlier study focused on the high-risk state, but not people who are overtly ill. In this case, we're working with young people who are ill. The grant funds us to work with people between the ages of 16 and 25. This is not really ideal because we certainly see some people who are 15 or 14. It also currently funds us for Cumberland County, which is a problem because we get referrals from all over, you know, southern and mid-Maine for sure. And it's the same lineup of services that we've been talking about. We essentially got the grant, the grant goes to the state, and the state is contracted with Maine Medical Center to do this. Got the grant largely on the basis of an intensive community-based treatment we had previously called the Anchor program, which the state, in its wisdom, despite its own data showing it was cost-effective and clinically effective, didn't continue to fund. The previous PEER program. Also, there was interesting legislation that we helped with that was about intensive mental health services to people in the so-called transition era. Typically, people, as they graduate high school or drop out of high school and go into young adulthood, they drop out of healthcare altogether. You know, they stop keeping dentist appointments and doctor's appointments, and the services available are fewer, and they won't. In the past, we all dropped off their parents' insurance at 18. That's not so bad anymore now with the Affordable Care Act. This was some legislation to address that, and I'm sorry I wrote the same numbers twice. It actually passed through the legislature with bipartisan support, which is kind of amazing, but not with enough to override the veto from our wonderful governor. So it's not a law, but it will come around again, no question. And then this now is the time, that's the name, Healthy Transition, that's the name of the SAMHSA initiative. So this is part of the focus of the intervention is on the interaction with the family. The best of families get into trouble when they have a young person who's really, really ill. And there's been a finding that when you see hostile, critical, over-involved, micromanaging parent interactions with their young person who's ill, these people do very badly. And it's easy to see how this would happen. This is a response to it's not just because you started off being a terrible family. It's a response to your son or daughters being ill. Now they're up in the upstairs and they won't come down. They won't go get a job or go to school. They're kicking the dog and they're maybe threatening you and they're acting strangely. They stop seeing their friends, and people start, out of the best of motives, start getting critical and start getting pushy, and can get locked into a pattern of interacting like that, which then is associated with markedly worse outcomes. Once that characteristic is going on in the family, you see higher rates of relapse and rehospitalization, generally much poorer function over time. And the silver lining is this is treatable by helping parents understand that this is an illness. It's not just that he's a bad person. I mean, this all sounds very simplistic, and it is kind of low tech. But by helping people understand this and meeting other families that are going through the same thing, this really can be changed, and that's really the core of a lot of these intervention efforts. Now, a fascinating thing, I don't want to spend too much time on this, is we know in lots of ways that negative interpersonal experience is associated with lots of bad things. And everybody's probably familiar with the ACEs study. It's getting a lot of press for good reason. That a lot of the people who are really difficult at the primary care level show all these kinds of problems. They're overweight, they don't take care of themselves, they have more diabetes and cardiovascular disease. And so briefly, there's a long series of slides on their website about the different things ranging from early unprotected sex to depression to heart attacks and cancer that are more elevated when you have a higher number of ACEs, which are adverse childhood experiences that have happened to you. It's very simplistic and yet really very powerful. So how in the world does that happen? And we know, adverse experiences associated with a number of mental illness problems, not just psychosis. But the question, just to talk about this very briefly, it's fascinating, but it gets a little tricky, and we're trying to think of what is feasible to study in the project we're doing right now. What are the transducers? What links negative interpersonal experience with your body and particularly your nervous system not functioning very well and getting into trouble? And we know about autonomic states, which on one hand can be very adaptive, fight and flight responses, but on the other hand, sustained arousal can be associated with negative effects. And talk briefly about this. HPA differences in cortisol. Inflammation is really being looked at a lot now. We all know about the autonomic system, fight and flight responses, and so on. And persistent activation of that, it has essentially toxic effects at the CNS level. I want to talk particularly about the hypothalamic pituitary system because I think that's really very interesting. I won't go into all of that. Wait a minute. Well, basically, we're getting input from the higher centers in the brain through the hypothalamus, and then down to the pituitary, which turn on through corticotropin-releasing hormones and ACTH, which then turns on the adrenal gland, produce cortisol, and there's a feedback loop. Well, we have lots of evidence that in a number of psychiatric disorders you see, and in responses to trauma, PTSD, you see elevations of cortisol and a loss of the diurnal variation. The cortisol is typically produced in the late night, early morning hours, so it's high in the morning, comes down during the day, goes up again. the next night. We know that in in a number of people, not all of them, not that specific, number of people with severe depression, particularly many people with psychotic mood disorders, will have elevated cortisol and a flattening of that diurnal rhythm. It tends to just stay high. And as I was saying, we know that's associated with some essentially toxic effects on the nervous system. I mentioned the in vitro thing. We also know that it decreases the neurogenesis or development of new cells in the hippocampus that needs to happen over the course of our lifetime. And so you see a shrinking of the hippocampus. So there are negative effects that continue. And we can talk more about this. Really, I find it really interesting and did some work on this with adolescent depression, University of Michigan. And we're hoping to be able to look at this in this psychotic population. There's a lot of work now on inflammation. So inflammation, again, is a good thing. It helps us fight infections and so on. But persistent inflammation is associated with a number of problems, associated with depression. You can take some of the pro-inflammatory cytokines, and if you give them to an individual, they essentially they have directly cause a depressive-like picture. So it's really, they have direct effects on the CNS. This underlies probably the association of depression with certain physical illnesses, not all physical illnesses, but these things were known to be more prevalent in depressive populations: asthma, rheumatoid arthritis, diabetes, obesity, atherosclerosis, also some malignancies, not all. And there's really a lot of interesting work going on with this, and it can pretty readily be studied. Lastly, just very briefly, this epigenetic history of business is fascinating, and basically in response to something like assault or sexual assault, you develop more methylation of certain areas of your genome, which then tangles it all up. No, I don't have the picture of it all tangled. So that it's not readable by the transcription processes, and it's essentially made that area of the chromosome not accessible. Now, this is part of normal functioning. This is why the same DNA in my, at the base of my toenail is making more toenail cells. The same DNA is made in constructed my brain. I mean, it's the same genome, which is then turned on and off selectively at different times in life and different areas of our body, and that's really just starting to be understood. But this so-called epigenetic process is part of it, and adverse experience has some negative effects that are really kind of interesting. And some of these studies, this first article, this is the Meany guy I was talking about. Some of the interesting findings are childhood maltreatment and early loss of parenting, having an effect through epigenetic mechanisms on a glucocorticoid receptor, which becomes less sensitive, and so the feedback mechanism doesn't work so well, so now you have too much cortisol floating around, to state that a little bit overly simplistically. But it's really, really kind of interesting. Recent study by Jim Hudziak at Vermont with a group in the Netherlands on stressful life experience in adolescence associated with epigenetic changes. So this is an area of work that's really kind of gathering steam. Rachel Yehuda at Einstein, really interesting work on changes seen in people who are Holocaust victims, survivors, and their children. So in most cases, these changes can persist through the lifetime of the individual, but disappear or weaken in subsequent generations. In some cases, they do get transmitted. So there are instances in which there's been a traumatic experience happening with the parent that's now that's resulting in more emotional over-responsiveness or hyper-responsiveness in that person's lifetime, which is actually transmitted to the children. So the children's nervous system is different, starting at the genetic level, because of what happened with the parent. So it's really a very troubling issue. And again, when you think of these families where adverse life experiences. It's not just this person, it's everybody else in the family. And so this kid's mom, and so on. And some of these things are then cascading down through generations. So the treatments, again, are largely, in this early intervention process, largely psychosocial. Certainly we're using medication aggressively, and that's a whole nother, actually I don't want to, a whole nother discussion. On the one hand, you want to be aggressive enough to turn off this process as quickly as possible, but you don't want to get people into negative side effects that's going to alienate them from using medication down the road. So it's a bit of a delicate balance. Since I'm in this project, I'm often the person involved with the meds. It's kind of ticklish and a little difficult, but so that's a big part of it. But so much of it is also about the family therapy and support and the therapy with the individual and helping them with jobs and schools. And also, particularly in the early phases, these so-called wellness aspects are really important. Omega-3s, vitamin D, exercise and sleep. Sleep is often a disaster with adolescent mental health in general. You see the kids staying up playing video games till 3 in the morning, and then they wonder why they don't go to school and they fall asleep in class. Question of what would anti-inflammatory agents be helpful, thinking about that variable. So I want to, this is an interesting thing if you want to Google. This is kind of amazing. Headspace is a program in Australia for very early intervention that really starts at the low-end wellness level and goes up from that. If you have a patient, any kid where you have any concerns, please give us a call. This is our phone number. Sarah Lynch is our program manager, program director. And so, again, we would want to see somebody where there's not necessarily a conviction that they've got this going on, but a suspicion or a concern. We would just assess them, and if they don't need what we do, then we help plug them into other things. So that, in a nutshell, is the idea. So any thoughts at this point? Questions? If you have any questions, give me a call or call Sarah, and I'd be glad to discuss a case and see if we can help out.